Hello, everyone. My name is Jamie Burgess-Flowers. I am a clinical assistant professor at the UNC Chapel Hill School of Social Work and the UNC Chapel Hill Adams School of Dentistry. My role at these two wonderful schools involves not only teaching social work and dental students, but also providing direct patient care in the student dental clinics. I am a clinical social worker, and my professional background has only been in healthcare. I have worked in primary care providing direct patient care as a behavioral health consultant, and have also trained interdisciplinary healthcare teams about trauma-informed care. So the model of trauma-informed care that I usually present on was developed by a wonderful organization called Saint A. Though their model is very, very comprehensive, it also takes 8 hours to complete. So today I am bringing you a much more brief mixture of information from not only Saint A, but also many other nationally recognized organizations who promote trauma-informed practices. So I want to start today by just saying thank you to all of you at UNC Health who are working every day to serve our patients during this incredibly stressful and unprecedented time. I really appreciate the opportunity to talk with you today about trauma-informed care and to try and be as helpful as possible as you prepare for your new roles in this pandemic. So let's go ahead and get started. So I want you to first understand, kind of get an overview of what we're going to talk about today and understand what I hope your takeaways, your biggest takeaways from this short presentation will be. So at the end of today, I hope that you have gained a better understanding of the definition of trauma, as well as the lifelong impacts of trauma. So that means how trauma can change the way a person interacts with their environment through behaviors, as well as what changes within the body due to trauma. I also want you to leave with a better understanding of how to utilize trauma-informed care strategies as a provider, as well as on your healthcare teams and with your patients, specifically during the COVID-19 pandemic. And I want you to keep in mind that today we are only talking about strategies for providing trauma-informed care with our patients. It is important to recognize the great importance of organizational trauma-informed care, or in other words, providing trauma-informed care to employees within the healthcare system. So my ask for you is that you take some time to reflect on this at the end of the training and consider how these interventions that we talk about might be translated to the care of healthcare team employees in order to decrease the stress response that healthcare workers are very likely experiencing during the COVID-19 pandemic. I will provide you with multiple sources for reference that do dive deeper into organizational trauma-informed care, and I hope that those will be helpful and that you'll be able to utilize them. So we need to first understand what is trauma-informed care. This may be something that you have heard about, and it may not be, but I want you to think of providing trauma-informed care to your patients as another universal precaution, such as PPE or personal protective equipment. So for example, do you use gloves with only the patients that you think might have an infectious disease? Hopefully not. I'm going to assume no. You use gloves as a universal precaution, right? So universally meaning with every patient. So trauma-informed care should be utilized in the same way. It is an approach to patient care that should be used with all patients, not only those who you think may have experienced trauma. Adopting a trauma-informed care approach has the potential to improve patient health outcomes as well as the well-being of healthcare providers. So what is trauma? Today we're talking about physical and emotional trauma, or you could also say physical, emotional, and psychological trauma. And within trauma, we have these three dimensions: the traumatic event, how a person experiences that trauma, and then effects resulting from the traumatic event. So an event is defined as an actual experience or threat of physical or psychological harm, or the lack or withholding of material or relational resources crucial to health and development. And then when we think about an experience, right, how someone experiences trauma, we're thinking about how someone assigns meaning to the event, which does depend on the perception of that particular individual and a lot of different factors. And then when we think about effects that people can experience from trauma, we're talking about results of the person's experience, right? So we're talking about neurological effects, physical effects, emotional, and cognitive. So a very large range of effects. And I will talk on the next slide about the research that supports that connection between a traumatic event and those neurological, physical, emotional, and cognitive impacts. It's important to remember that there is a lot of variability when it comes to trauma. So think about, even if you and I lived through the same traumatic event, we could each experience it very differently. And as a result, we're going to experience very different physical, emotional, and cognitive impacts or effects. So if we review the definition of a traumatic event listed here, it's really easy to see why the COVID-19 pandemic is a traumatic event for many people. Thinking about the threat of physical harm from COVID-19, the loss of employment and the resulting lack of material resources, or even just the loss of social connections, otherwise known as relational resources, all could constitute a traumatic event. So let's talk about that research and the data that I referenced on the earlier slide. So we're going to talk about the Adverse Childhood Experiences Study, otherwise known as the ACEs study, which was a landmark public health study conducted at Kaiser Permanente between 1995 and 1997. So over 17,000 patients were surveyed in the study using a survey tool with questions spanning different types of adverse childhood experiences. So some examples of what an ACE, or an adverse childhood experience, is could be childhood physical abuse, childhood sexual abuse, and various types of household dysfunction that a child could experience under the age of 18. So there were several findings from this study that are really important, but two of the most important takeaways were that there is a very strong connection between adverse childhood experiences and long-term negative health outcomes, okay? And then not only that, but the more adverse childhood experiences in someone's history, the higher the risk of negative outcomes. So basically, this study finally brought forward evidence that showed the medical community that early adversity in life matters because it can have lasting impacts on a child's life. And you can see in this image that those lasting impacts, or those well-being outcomes that I'm discussing, are things like injury, mental health, maternal health impacts, infectious disease, chronic disease, adopting risky behaviors, and different opportunities like education, work, and income levels. So let's walk through how adverse childhood experiences create their impact throughout the lifespan, utilizing what's called the ACEs pyramid. So starting at that very bottom block and moving up from conception to death, research shows that ACEs can cause disrupted neurodevelopment, which means that brain development is stunted or delayed. So when a child has stunted or delayed brain development, that can lead to social, emotional, and cognitive impairments. An example of that could be speech and language delay, emotional outburst, or difficulty learning and retaining information. So I'm sure you can imagine how these types of challenges can make it really difficult to create social relationships as a child and to be successful in school. So let's imagine a teenager who has struggled with social relationships and academic achievement, and think about how they may utilize health risk behaviors to cope or to find connection. So when we think about adoption of health risk behaviors, examples include smoking, substance use, alcohol use, self-harm behaviors like cutting, and high-risk sexual behaviors. So over time, those behaviors can contribute to infectious and chronic diseases and long-term social and relational difficulties. In turn, the lack of healthy, meaningful social interactions combined with chronic disease can decrease a person's life expectancy, which can lead to that early death. So we now understand a bit more about how trauma can create its impact on a person's social, psychological, and emotional health. But let's take a closer look at how trauma can change the way that a person interacts with the world around them, even when they have experienced typical development that has not been affected by traumatic events. We need to start by understanding how our bodies manage under stressful or traumatic conditions, or when we experience an event that triggers stressful or traumatic memories. So let's start by understanding the fight, flight, or freeze response. This is also known as kind of your survival mode. My very favorite way to describe this is to imagine that you're camping. And while you're camping, a bear comes across your campsite. So what would you do? Um, if you think about it, your body has this wonderful ability to kick into survival mode and make a really split-second decision about whether you're going to fight that bear, whether you're going to run away as fast as you can, or if you're just going to play dead, right? So we think fight, flight, or freeze. Regardless of which one you choose or your body chooses for you, you're going to experience that same chemical response, which involves multiple chemicals, but the ones that we probably know best are cortisol and adrenaline. Working in healthcare, I am sure that you have felt the effects of an adrenaline rush before and probably could describe that and think about it in pretty good detail. So as you probably know, it can be a very physical experience. So in the real world, when the stress response is activated, we may experience an array of responses that represent that fight, flight, or freeze. And those responses are going to be on a continuum from arousal to dissociative stress responses. So as you can see here on the screen, I have several examples for arousal and dissociative stress responses, but it's important to know that these are not all encompassing. So when we think about what an arousal stress response looks like, or some signs and symptoms of an arousal stress response when a person is experiencing that type of stress response, we're very likely to see things like increased vigilance. We can notice that in a person's body language, but also their type of eye contact or eye movement. Impulsive reactions, anger outbursts like yelling, aggression. Aggression can look like threats. It can look like physical aggression, verbal aggression, signs of anxiety, and exaggerated response. So a response that just doesn't match the context of the situation. Dissociative is going to look pretty different, right? It's the other side of this continuum. So we might see a patient who looks withdrawn from the situation or the circumstances around them. It might look like compliance. You may think this patient is doing exactly what they should be doing. They may seem a little spaced out. They might show a lack of connection to their body or the situation, and that may cause some loss in time or loss in memory. So my favorite example of this is from my real life experience in primary care when I was met with a teenage girl, a young teenager who disclosed a history of sexual abuse. And so within our very short visit, we talked a little bit about that, and then we discussed a follow-up plan, which was to meet back in 4 weeks for another appointment. And we talked about some homework, practicing some coping strategies and some other things like that. So she comes back in 4 weeks and she comes to the appointment. She remembers meeting with me, but she has no recollection of the homework that was assigned to her. And I think upon reflection, I definitely realized there was some withdrawing and some what seemed like compliance. There was a lot of yeses and head nodding, but really I think that she was kind of spaced out and had a little bit of a lack of connection to the present time. I think it's also important to note that in small doses, your fight, flight, or freeze can actually be really helpful. For example, when you experience a crisis at work and you're able to move more quickly than usual and access higher vigilance, it may feel like you have an extra boost of energy. However, for someone who has experienced a traumatic event, they may experience difficulty with an increased stress response, or in other words, a frequent triggering of their fight, flight, or freeze response. So people who experience an increased stress response in that way, they may end up with a body permanently set on high alert. So in other words, they may struggle to regulate their emotions in what is considered a socially acceptable way. And therefore, they display those arousal and dissociative behaviors that we talked about quite frequently. This is also referred to as emotional dysregulation. So I like to think of that as a body that often has a fire burning and doesn't really have enough water to put the fire out or even to calm the fire down. You can easily imagine how this could lead to conflict with people in their lives, including their healthcare team specifically. I often think of that patient who seems to come in swinging, ready to argue, ready to fight. And if you can envision a particular patient with that description, or probably a few, then you have likely already interacted with a patient who struggles with emotional dysregulation. So in addition to emotional dysregulation interfering with positive social interactions, it's important to understand other ways in which relationships may be challenged or negatively impacted by traumatic events. So this visual that you're looking at was created by Dr. Bruce Perry, who is a nationally recognized expert in trauma-informed research and evidence-based practices. He developed this visual to help people understand how negative experiences in childhood can impact our ability to tolerate various relationships into adulthood. So if you look at this, you'll see down in the bottom left-hand corner, an example of how children who have early experiences that are positive, safe, and nurturing develop a much broader capacity for engaging in a larger range of relationships. So that broader capacity, we're talking about being able to interact with casual, routine, personal, all the way to intimate types of relationships. And if you look at the top left here, you'll see that children who have adverse or traumatic experiences often prioritize safety, and that can restrict their capacity for engaging in a range of relationships. So even those that are considered very casual, which you'll see that very, very slim area of green up top is showing how small that capacity could be in engaging even in casual relationships. This often plays out in our everyday interaction with patients. So think about those who will embrace a warm gesture and have a positive visit with one member of their healthcare team, then yell at another member only moments later. So we have just learned about multiple ways that trauma can have a negative impact on how a person interacts with the world around them. So now let's look at how those interactions may change a person's worldview, or how they view their environment and the people that they interact with every day. So as you see here, there's a big difference between the worldviews of someone with typical development and someone who may have experienced developmental trauma. So a person with a typical development may typically feel like humans are generally safe, whereas someone with developmental trauma may experience humans on a regular basis as being a threat. And that relates to the next box, which talks about that relational tolerance we discussed versus relational sensitivity. So being able to tolerate a much larger range of relationships and interactions versus being more sensitive to even some of the more casual and routine interactions with folks. Folks who have a typical development generally feel that bad things that happen are accidents. And I can speak from personal experience with my patients that folks who have a history of developmental trauma may feel like bad things happen on purpose. So I've had several patients who have stated to me, bad things just always happen to me, or this is just kind of my life. And I also have other patients who feel like bad things happen because I brought this on myself or I deserve it, right? So that's a very negative worldview to have, and it can negatively impact a lot of interactions with people around you. Folks with typical development, typically risk is positively reinforced. So you think about risk like taking a new job or applying for an educational program. Someone who's had developmental trauma and feels that safety is the priority versus opportunities to thrive may feel like if I already have a job, if I'm already employed, I don't need to risk it, right? I don't need to take that chance. I need to make sure that I have safety and security. And so I shouldn't apply for other jobs or other educational opportunities that could threaten my safety and security. So trauma not only changes an individual's perspective on the world, but it can very likely also change the world's perspective on an individual with a history of trauma. When we are working with patients who present with challenging behaviors, it is important to assess how those behaviors and interactions may impact our own perspective on patients with a history of trauma. So it's really important to remember that changing your perspective on a patient is a trauma-informed intervention in itself. So it might sound easy, but it's actually really challenging. So first, what we need to do is look at, go ahead and assess our traditional viewpoints on patients who present in this manner. So if you have a patient who is presenting with those signs and symptoms of an associative stress response, or an arousal stress response, you may see a patient who's acting out. You may see a patient who seems rude or mean or has manipulative behaviors. Now, dissociative may look like slow or delayed, like we talked about, and non-compliance can kind of present in either arousal or dissociative stress response. So when we see a patient who we typically have these points of views on, right? We observe that behavior, and the first thing in our mind is they're acting out, they're rude, they're manipulative, they're just not compliant. But to shift our perspective, we need to take a step back and think about what we've already discussed today. So thinking about, is the patient who's acting out or being really mean or aggressive, is that they're emotionally dysregulated? Could it be that they're lacking the skills that they need to kind of turn down that fire, right? The patient who is being rude or mean, could it be that they're scared, that their fight, flight, or freeze is being triggered? Even though we told them it's a 20-minute wait for your prescription, they just hear, I can't get my prescription right now, and they're going into survival mode. Another thing to consider is adaptive patterns. So a behavior that is a pattern that a person has kind of learned over time, they've had to adapt to their experiences in the world around them. So thinking about those kind of outward, what seem maybe manipulative or aggressive in some way, those types of behaviors, it's important to think about how sometimes people have just learned that this is what works for them, right? When you're prioritizing needs and safety, if you've learned that, for example, bullying type behaviors has worked in the past with healthcare teams, that's an adaptive pattern, and you may continue to use that over time to be able to get the things that you need for you and your family to survive. Remember that for most people, the COVID-19 pandemic will be associated with increased uncertainty, higher levels of stress, and loss of power and control. So again, living through the COVID-19 pandemic can be considered a traumatic event, and people will experience it in a variety of ways. We should expect most of our patients to be operating in that survival mode we discussed, and therefore, we may see a range of impacts on human behavior. So what in the world can we do to help provide some level of comfort and ease to our patients? And how can we disprove some of those negative worldviews that many patients hold? One of the most evidence-based interventions for providing trauma-informed care is to increase the safety that our patients are feeling, both emotionally and physically. So 3 main aspects of safety to consider, and I would urge you to write these down and make them your mantra, are predictability, transparency, and consistency. So these are very common themes that emerge across all literature on trauma-informed care. So let's address physical safety first. Some things that you can do to promote physical safety for your patients. I have some examples listed, and we'll go through those together. So for example, making sure all parking lots, common areas, bathrooms, entrances, and exits are well lit. You could also consider ensuring that security guards are readily available, and consider stationing them at building entrances and exits to monitor the flow of traffic in and out of the building. This is something that's been shown to help prevent groups of people from congregating, loitering, or smoking directly outside of buildings, which may provoke a stress response for some patients. Another thing to consider is noise levels in waiting areas should be kept low if possible, and staff should avoid using overhead loudspeakers when possible. Other ways to promote this can be to avoid showing news stations on televisions and to instead consider playing soothing music. You could also consider decorating with warm colors and artwork, and creating calm spaces for patients to just kind of be in the calm, or use those spaces as places where people can fill out sensitive paperwork. I do recognize that this may not always be possible due to limited funding or limited control over resource allocation. However, small changes can make a really big difference. So for example, a group of team members at my primary care clinic in the past that had a representative from each profession did a patient walkthrough one morning. They wanted to try to simulate the patient experience, at least from a visual perspective. So as a group, we found there was missing signage, and the artwork in the lobby, which was the first thing that you saw when you walked in, was a picture of a young girl having her ears checked. And she had a big frown on her face and definitely looked like she was in distress. So that was something that was a really easy, cost-free change. We just changed it out with a more positive piece of artwork that was in a lesser traveled hallway. So moving on to emotional safety, and I have a lot more ideas around emotional safety, and I kind of split them up into communication skills that are a little more basic and communication skills that are a little more advanced. So starting with the basics, we go back to this idea of consistency, right? So be consistent if at all possible. You can do that by welcoming patients to ensure that they feel respected and supported. Various examples of clinics across the country. There are various examples of clinics across the country that serve vulnerable populations, and they employ hosts that are there specifically to greet patients upon arrival and help them navigate the building and services, because they recognize that many of their patients have traumatic experiences in the past. You could use positive and welcoming language on signs, forms, and materials. So one example of this would be, instead of a sign that says no cell phone use in the lobby with an exclamation point, you could have a sign that says please refrain from cell phone use in the lobby. Very, very small change, but with a very big impact. Policies for communication are really essential. COVID-19 will likely result in longer wait times and frequent policy changes. Consistency is important for patients and can help de-escalate patients who may already be experiencing higher stress levels than usual. Some ways that you can address this would be to offer as much notice as possible when changes are necessary, because we know they will probably be necessary. And recognizing there's just a lot of misinformation being spread about COVID-19. So have a consistent message for education and information that's free of medical jargon. And last, keep communication lines open with patients for questions and concerns. You can do this simply by asking patients at each stage of their visit, when you start and when you finish that stage, do you have any questions? And when a patient asks a question, even if it seems silly or even if it's something that has already been addressed, validate their concerns and validate that that question was a good question and you're glad that they asked it. And even if you're not able to answer the question yourself, let the patient know who can answer that question and help get them there. So some more advanced communication skills include transparency and predictability. So when it comes to transparency, we're talking about explaining the why behind decisions based on policy and or practice. And predictability, so giving the patient a heads up on what to expect. So by knowing what to expect, patients can utilize tools they have for promoting calm and a decreased stress response. One example is, before an exam, explain to the patient what parts of the body will be involved, what equipment will be used, what they might feel, what they might hear, and if any chemicals will be used, what kind of smells they might smell. So some more advanced communication skills. I really want to focus in on choices. Offer choices, even in situations where choices are really limited or they may seem really insignificant, because I can assure you, even small choices that a patient can make, they are going to be significant to their care and their response to their care and their experience. This may decrease anxiety and give the patient a sense of control. So some examples of this, giving the option of keeping an exam room door open or shut, asking the patient, which arm would you like me to place this vaccine? If you are placing a vaccine or starting a procedure or something else, asking the patient, would you like to count to 3 before we get started? Give the option of shifting an item of clothing out of the way rather than putting on a gown when an entire area doesn't need to be visualized. Offering a pillow for a patient's back rather than putting them in the supine position. Offer the option of a mirror to see procedures or exams that are out of the patient's visual field. Offering options for patient to signal discomfort of distress non-verbally, like raising their hand. And this is a great example I've seen in the dental field, where you are literally working in a patient's mouth and they cannot communicate to you verbally. So whether or not it's an example like that, or if it's an example where, let's say, a patient may feel pressure, but they shouldn't experience pain, and you want them to know, if you do feel pain, I need to know, and how might you feel comfortable communicating that to me other than verbally, right? Raising your hand is a great example. And last but not least, let the patients do what is most comfortable for them. Comfort is different for every person. For some people, it might be leaving socks on. It might be leaving a jacket on or another item of clothing. It may be listening to music. During a procedure or during an exam, they might want to keep in headphones or play music on their phone without headphones in, or just having a person or a stuffed animal or something like that accompany them, some symbol of luck or health or comfort. A couple of other advanced communication skills that I want to end with. Prioritizing relationships with patients. I cannot tell you this enough. And I'm sure that you have learned this as a healthcare provider, that prioritizing relationships with patients can help you to know what their particular values and goals are, and to help you really align with that patient for the best possible care. A couple of ideas when it comes to prioritizing relationships. You need to utilize attunement to be able to prioritize the relationships. Be attuned to their relational sensitivity. So thinking about that kind of green and red visual by Dr. Bruce Perry that I showed you guys about relational tolerance and relational sensitivity. So understanding, is a casual or routine interaction with their healthcare team member a little too much? Do I need to back off a little bit, pay attention to their nonverbal cues? And culture plays a huge part in this. So being attuned to the cultural differences, understanding that just because from your perspective, strong eye contact is a good thing, there are certain cultures where maybe strong eye contact is actually disrespectful or inappropriate. And that is something that you might not get from the patient. And so keeping that in the forefront of your mind is very important. Also consider ways that you can help patients regulate their emotions by promoting sensory-based activities. So you can do that by touch, sound, sight, smell, vestibular, and movement. The really cool thing about this is that these are actually derived from calming activities in the womb, and even that adults help promote in infancy. So just a couple of examples. So with touch, weighted vest, that's something I hear about in the dental world often, is the kind of lead vest that they utilize during imaging. Sometimes patients will say, that feels really comfortable actually, can I leave that on? And they'll allow them to leave that on for whatever part of the exam that it's safe to do so. Music versus silence for sound is really important. Sometimes our patients might really appreciate silence, and sometimes that music may be helpful. And I also want to point out sight. Pictures and videos are something that is actually could be really accessible for our patients, because many of them have a cell phone on at all times. And if a patient is struggling to regulate their emotions, if they're feeling very anxious, it might be helpful to bring up, are there photos, are there videos you can show me of your family, videos that make you laugh, photos that bring you joy, of places that you visited possibly that bring you calm. So it's important, again, to be attuned to your patient, know your patient, and then help them find ways to regulate. And so I want to end on this quote. How you treat people during tough times says more about you than how you treat them in the good times. So as we've discussed, traumatic events can bring some of the most challenging behaviors out of people. During this pandemic, one of the most trauma-informed interventions we can employ is to adjust our expectations of our patients and our team members. We are all doing the best that we can, and extending a little bit of compassion to our patients and each other will go a very long way. So here are the references and resources that I promised. So I hope that some of these will help you to revisit trauma-informed care for your patients, but also within your organizations. And I just want to end on a very, very big thank you. Again, thank you for letting me be a part of this. Thank you for hopefully listening to what I have to say and possibly being able to implement some of this. I have my name and my contact information at the bottom of this slide, because I really want to encourage you to reach out to me. If there's any way that I can support you with patient care or support you with your teams, please let me know. And again, thank you and good luck.